Everybody, Dr. Burkhart here. I'm going to go over your diet and mental health activity. So the first part of this activity was to watch this TED Talk. Essentially what I was trying to do here was just get the idea in your head at least that diet definitely plays a role in mental health. Now there are a lot of videos out there that you can go watch if you're really interested in this. I just picked a TED Talk because they're generally a little shorter, a little more interesting, and it really gets that point across about, what are the possibilities with diet and mental health. The next part of the assignment, I had you actually complete a dietary frequency questionnaire called the Diet History Questionnaire 3. So you were able to complete this and then actually view your results at the end. And it kind of gives you a breakdown of what your diet looks like. So let's talk very briefly about dietary recording and the types of dietary recording that there are. So there are really, I would say, 4 to 5 main types of dietary recording. The first type of dietary recording would be something called 24-hour recalls. Now these are essentially questionnaires where you send it to someone or you have a patient fill it out and they tell you what they ate in the previous 24 hours. In a research world, we might repeat these in 3 randomized occurrences so that you can get maybe a good representation of what people eat. Obviously, some limitations to this 24-hour recall is that not everybody's diet is the same every day. So if you only do one, you might be limited in what you're catching in that patient's diet. However, they're easy, they're fast to do, and they don't take a lot of expertise to administer. The second one is a food frequency questionnaire. And this is basically what you guys did with the DHQ. Now, the strengths of this is they're a little bit more thorough, a little more complete. However, the kind of limitations to this, as you could tell, was it takes a long time to complete these, and you're still going off of memory. So you can forget maybe what you ate in the past month. You're really taking a lot of guesstimations. You're not really sure. So although they do a pretty good job of estimating someone's diet, there's some definite limitations there. A third type is journaling. So usually these take kind of the form of 3, 5, or 7-day diet journals where you actually have someone record everything they eat for whatever specified period of time that you're having them record it for. And these are usually very intensive. Generally, it's not just what food you ate, it's how much of what food you ate, what type of food is it? Is it chicken that's baked, chicken that's fried? These really specific questions that need to be answered to make a good journal. So obviously the strengths is that you can get a really accurate estimation of someone's diet, especially if it's a week long. But the limitations is that it's really intensive for the subject. And a fourth one that I'll talk about today is using a weight or weighing device or a scale. So actually weighing your food out. So this one is obviously going to be the most accurate because generally along with weighing your food, you're taking a picture of it and then you weigh how much of you eat and you record both of those things, and it's generally given to a dietitian or someone with that expertise where they can actually then put it into a program that will spit out numbers like you guys saw with your DHQ questionnaire. So this one would be probably the most accurate. So if we're going along accuracy, probably going left to right, going from less accurate to more accurate. However, in the converse, going right to left, these ones over here are much more useful for research because they're so intensive and so burdensome on patients. However, these are much more clinically useful because they're so quick, generally easy to do, and usually they can have automated outputs as well. So that's your overview of dietary recording. Okay, for the third part of the assignment, you're essentially going to use your own dietary results to apply to this case, which was an 18-year-old that came to your clinic. You're an outpatient psychiatric pharmacist for the first time, basically for an appointment after staying in a hospital for a suicide attempt and a new diagnosis of major depressive disorder. As you can see, the patient has a normal BMI. They have a current diagnosis of ADHD and GAD. And essentially, they were on these medications. So the point of the case is that they're discharged on these medications they improved, they are discharged on the same medications they started with, in addition to a new SSRI. And so the physician's really interested in taking a look at this patient's diet to see if there's any sort of recommendations, evidence-based recommendations that you could provide using your dietary results that could maybe play a role in the management of this patient's depression. So what we're going to do is we're going to look at my dietary results, and then I'm going to show you kind of just an idea of what you guys could have gone through to make a recommendation. Again, these recommendations were fairly short, but I really just wanted you to begin to look at some of the literature behind diet and mental health. Okay, so here we are in my results here. What you can see is that I was mostly in the range, a little bit low on the carbohydrates, in the range of protein, and I was high on fat, and then actually high in saturated fat. So I guess I need to work on this part of my diet here. But all in all, I'm not too crazy out of the ranges of these kind of recommended dietary proportions. As you can see, the report also gave you daily food group targets that you guys saw. So for me, I guess I was kind of near the target for grains. I was definitely under for fruits. Need to work on that. Dairy, I guess I'm on about target there. Pretty close to target on vegetables. Protein, much higher. I guess I like my meats. And then the report gives you selected macronutrients. So these are your big kind of groups, being carbohydrates, proteins, fats, those types of things. So as you can see, again, I had apparently too much carbohydrates, although I think it said I was low in the beginning. So that's an interesting dichotomy there. Protein we know is high, fiber I'm low on, and then it goes through all these vitamins as well, which I won't make you go through. But it's a very interesting report in terms of the detail it gives you and what it's able to output just from spending about an hour putting in what foods you've eaten in the past month. Okay, so where did I start with trying to make a recommendation? I was really interested in seeing in the literature if there's any real good evidence linking macronutrients to depressive symptoms. So what I did was search literature, and then I found one of many studies that I actually found, but I'm going to show you the one study that I decided to highlight in my recommendation. So here's the study that I found. It was fairly recent. Let's see, it was published in March of 2020, so just came out, and it's called The Association Between Macronutrient Intake and Depression in the United States and South Korea. So I'm really interested in the United States part here. And so let's go through the results to see what, if any, link between macronutrient intake and depression they found. So in the study, what they did was they used a survey called the National Health and Nutrition Examination Survey. So NHANES is something that the United States government puts on year after year. And so it goes through a myriad of different types of questions, from lifestyle to socioeconomic to depression to actual dietary intake. So these surveys can differ in terms of the ones they do from each year to each year. However, NHANES is an open source data set that many researchers have used to publish on. So what they did is they used NHANES to look at macronutrients, and specifically they wanted to look at fats, carbs, and proteins. And so what are the recommended cutoffs for fat, carbs, and proteins? They are 20 to 35% for fats, 45 to 65%, 60% for carbs, and 10 to 35% for proteins. And so these are standardized cutoffs that are study-based, and they have a name to them, but that's beyond what we need here. So essentially, these are the accepted cutoffs for fats, carbs, and proteins, and they wanted to see if being out of these ranges was associated with depression. So what they also used from NHANES was the PHQ-9, which you guys have probably heard about before. That's basically a self-administered depression questionnaire with 9 questions. It's very quick. It's very easy to administer. And what they were looking for, their cutoff was scores greater than 10 indicating depression, but they also looked at it as a quantitative trait, looking at just the relationship between these macronutrients and a higher or lower PHQ-9 score, aka depressive symptoms. So they pulled out this publicly available NHANES data, where it included both dietary data that included macronutrients and the PHQ-9 scores. And what they found over about a 10-year period was of about 60,000 administered surveys, they had 15,296 available for analysis. And of this sample set, they had a depression rate of 7.7% based on the PHQ-9 score of greater than 10. Now, with these 15,300-ish patients, what they did was they compared them between those who had depression and those who did not. So that would look like the following. So the non-depressed group and the depressed group based on the PHQ-9, and they compared them on various factors. And what they found was that there was no significant difference based on the following factors. Age, hypertension, diabetes, income, education, calories, carbs, and fats. However, the one difference they found between the two groups was the following. There was a higher protein intake in the non-depressed group as compared to the depressed group. So an interesting finding that there's no significant differences in all of these factors, including calories, carbs, and fats. However, an increase in protein was predictive of being non-depressed, and a decreased amount of protein intake was predictive of being depressed. Now, additionally, in the study, they actually had access to surveys from 2005 to 2016, so they looked at the odds ratios of being depressed with the three major macronutrient groups over the years from 2005 to 2016. And what they found was as follows. An increased odds of being depressed with increased carbs from year to year. A decreased odds of being depressed with increased protein intake, which is what we saw from the main analyses that were presented just previously. And then finally, they found no difference when looking at increased fat intake for the risk of depression. And what they actually found was that when they actually adjusted these for various factors, including age, gender, marital status, BMI, hypertension, dyslipidemia, chest pain, so basically for everything they could get their hands on, and they were able to do these powerful adjustments because their study included so many patients, they found that the results were the same. So, based on this study, I think there's reasonable evidence, especially based on the NHANES United States portion, that we could recommend very global changes to a patient's diet, where we could tell them maybe lower your carbs if possible, increase your protein intake, and then maybe from a physical health standpoint, you might want to make a fat recommendation, but from a mental health standpoint, we really wouldn't make a recommendation there. So that's an example of a paper I used to come up with these three different macronutrient recommendations. So one final note I'll make is that I went further into the diet kind of literature to see if there are further recommendations I can make. And one area that I won't go into a great amount of detail like I did with the previous paper is within so-called inflammatory diet. And so there have actually been several meta-analyses, not just this one, that have found that a dietary inflammatory index, which is an actual measure of how inflammatory or pro-inflammatory your diet is, has been significantly associated with depression across many, many studies. And so what really makes up an inflammatory diet? It's a diet that increases certain inflammatory factors in your blood, such as CRP, TNF-alpha, IL-6. Some indices also use IL-1 beta, IL-4, and IL-10. So when you have foods on board and this has been extensively studied in the diet literature, that cause increases in these factors, they mark these as so-called pro-inflammatory foods, while if you have foods that decrease these factors, which there are a few of, they actually call them anti-inflammatory foods. So what are some examples of foods that you'd want to avoid because they're pro-inflammatories? Essentially, those would be your things like we talked about carbs. Increased fat is actually on the inflammatory side. Iron, certain meats, so actually too much protein can increase your inflammatory index, and which is interesting since we saw kind of the opposite in the NHANES, where an increase in proteins actually would decrease depression. So there's some sort of muddling of the analysis of proteins versus specific types of meat and inflammatory factors happening there. And then what could be likely okay to actually cause an anti-inflammatory effect? And these are really few and far between, but they are kind of your leafy greens. Coffee's actually been associated with an anti-inflammatory effect. Wine and beer has also been associated with an anti-inflammatory effect. And interestingly enough, pizza in one of the inflammatory index studies was associated with a decreased amount of inflammatory markers in the blood. Probably not the amount of pizza that I eat, but nevertheless, I guess there's some good things in pizza. And then finally, that's kind of complicated. So what would you be your actual recommendation to a patient to decrease their inflammatory index and therefore theoretically decrease their risk of depression? And for that, I went to one of the most used and well-known diets out there, the dietary approaches to stop hypertension. There's actually been very strong evidence that shows that there's a decrease in serum inflammatory markers with the DASH diet. So you could easily recommend this to a patient if you wanted to take this so-called inflammatory approach to decrease a person's inflammation, decrease their risk of depression. And a DASH diet, as we all know, is really balancing out those food groups. So increasing whole grains, poultry, nuts, fish, veggies, but decreasing fat, red meat, sweet drinks, and refined grains. And in this study, they actually found there's a decrease in C-reactive protein, or CRP, in the blood. And then finally, what I'll say, which I didn't mention at the beginning, is that there has been a very active area of research for inflammation and depression risk, looking at actually anti-inflammatory drugs for the treatment of depression. So this is a continuing, ongoing area, and diet definitely plays a role here. Okay, so I hope that little brief overview was a little helpful to you. I'm hoping that what you guys got out of this was a new view of your diet and how it can actually affect your brain function, especially psychiatric health. I hope that you guys got a little bit of a view on how one analyzes your diet. And then with your literature searches, I hope that you found at least a few interesting studies that help support some of the dietary recommendations that you wanted to make. Thank you.